So my name's Whitney. I work in the ER as a nurse, and I'm getting my doctorate degree at the U right now. So this project is kind of for school, kind of for work, and it's mainly emphasized by Dr. Youngquist. Hopefully you're all familiar with Dr. Scott Youngquist. So this is conjunction with, actually, why you did surveys, which I appreciate your help, is to actually, this is going to hopefully be published. This is something we're trying to implement nationwide. And so they're finding with research that sepsis is a big ordeal in our country, and you guys are the first line. So you have a huge role in identifying and helping us treat patients better. So that's why I'm here today, is really to kind of emphasize that. And hopefully this will be interactive. I have treats for you later. Our goal is to hopefully this will be a tool for you, not to cause more work, but to just be a tool in your toolbox to benefit you. And then on our end, we hope to work better with you. This is really in collaboration to have better ER and pre-hospital EMS teamwork. So I put PowerPoint together, but we'll kind of just talk briefly. How many of you have heard of sepsis before? Are you familiar with the term? Okay. Hey, you're in the 50% that actually has heard the term. A lot of people haven't. So these are a few objectives today. Really, it's to help you feel comfortable first recognizing signs and symptoms of sepsis and feeling comfortable with interventions. And we're going to talk about something Dr. Youngquist wants to implement. So you actually are going to be our pilot program group. So we're going to have you implement a checklist or a sepsis bundle. I'll probably use those terms inversely today. And with this, we're going to actually get feedback from you to see if this is beneficial or not. Because if it works, we're going to actually take it to all EMS crews. And then we have other pre-hospitals that, or clinics, I guess you could say, that want to have education on this because it actually is really important for patient outcomes. So why does it matter? These are some national statistics, okay? This isn't just Utah, this is nationally. So there are about 58% that have heard the word sepsis. Whether or not they can identify what it actually is a lot less than that. Over 1.6 million cases a year, and that is continuing to increase over the past few years in the United States. And then each year it kills over 258,000 people. That's a lot of lives when we think about caring for people and wanting the best for them. It's the third leading cause of death in the United States. So it's right behind cardiovascular disease. So that's high blood pressure, heart attack, that's like the whole cardiovascular issues, and cancers if you lump them all together. That's not individual. Other than that, this kills more people than strokes, kills more people than just heart attacks alone. So this is a huge concern in healthcare right now. And then look at the cost. Over $27 billion was spent just on sepsis care in a hospital nationwide. So this is costly to our nation as well. And then you can see children are very susceptible to this. It's a really big concern with kids. Worldwide, obviously we're a more developed country, but you can see it's impacting worldwide as well. So it is the #1 killer of hospitalized patients in the United States. So in Utah, that is the case. That is the case at the University of Utah as well. 60% of survivors will experience poor mental state or physical impairments. I don't know about you, but if I was sick and put in a hospital with this, and then you come out with a physical or a mental ailment, that would be tough to have a big lifestyle change with that. It is actually, like I mentioned, the leading cause at University of Utah Hospital. It is the case in all our hospitals, actually across the state, not just the U. 42% of those who die have been diagnosed with septicemia. So people can develop it once they're, in a hospital and sick with something else, but a lot of them come in pre-hospital with this already. And then it's more fatal, like I mentioned, than heart attack, stroke, or trauma. So I know there's a huge focus on trauma, strokes, get people there. I want you to think of sepsis in the same category, sepsis time. So if we don't act quickly, the outcomes are very poor, just like with heart attack and strokes. So here's some numbers for you just to kind of put this in perspective. So we have a statistician at the U that it just runs numbers on sepsis. And from August of 2017 to September 30th of this year, we've seen 1,132 patients come through the ER with sepsis, or they get the diagnosis after a workup. 69 fatalities because of that. So how does and why does this matter to you? Well, here's where numbers come in. So you brought in via EMS. So this, we couldn't separate different crews and teams. We're actually going to work on that, and I'll show you how in a little bit. But this is 308 were brought in via ambulance. And so if you look at the numbers of fatalities, 32 of them were EMS too. So you bring in sicker patients. So the sooner we can have interventions, the better. Feel free to pipe in if I miss something as well. So what is sepsis? So all of you said you have heard it. Does anybody, now I have a little cheat sheet up here for you, but anybody want to define it in their own terms, what sepsis is, or what you feel like you've learned with your experience thus far? Yeah, absolutely. That's a great, simple way to put it. So there's a lot of things that can cause it, but basically put, it can be bacteria, it can be fungus, it can be viral, but majority of the sepsis cases are bacterial. So it gets, people have an infection from a urinary tract infection, they have pneumonia, or some respiratory flu can even lead to this. GI stuff, so they have a bowel obstruction or something like that going on. Their skin, have wounds is a huge one to keep in mind. Neurological, so altered mental status, brain attack or stroke previously, and then any previous bloodstream issues. So if they have leukemia or other cancers, that also puts them at risk. So what happens is these infections in a local spot of their body aren't treated in an effective or timely manner, and it spreads and gets into the bloodstream, and then we have a real big issue when that happens. So it is life-threatening organ dysfunction that is caused by infection. All these big medical terms, we'll try to keep it simple, but there's actually 4 phases, and I'm going to break them down just so you can kind of see the breakdown of it. But sepsis, you'll see, is 2 of the SIRS criteria and a confirmed infection. So there's kind of stages. The earlier we catch it, the better off for the patient. And then again, these are symptoms. So for you, if you get a call and you're called out and you see a patient that has these symptoms, I hope that a red flag will start to kind of go off. Like, am I thinking sepsis? Do they need to be transported quickly to the hospital? So a cough, any red skin, especially if they have a wound. That wound is oozing, it's purulent, there's some nasty discharge coming from the wound. Rigors, flank pain, so they're kind of lower back pain. Dysuria, they're not able to urinate, especially in the elderly, is a huge one to think of. And then diarrhea, especially if it's been going on for a day or 2. So sepsis risk factors. So these are kind of the people, anybody's at risk. There's no exception saying just because you're this age, you're not going to get sepsis. But these ones are the high-risk population. So the very young, usually they say about 8 to 10 and younger is considered very young. The age 65 and older, any patients that have recently had surgery, usually within 2-week window post-surgery is when people end up getting sepsis, is usually in that window. Immunocompromised, so your cancer patients, your transplant patients, and your AIDS patients. Chronic illness such as diabetes, renal failure, and then obviously IV or the homeless population where they're exposed to a lot of different things. So people to keep in mind with, whoops, wrong way, this. So here's your stages. So we'll kind of break these apart and work through these, and I don't expect you to remember it all. I still have to look at a paper sometime to know all the criteria, but I want you to just kind of think of how this progresses. So people that you go out on, really vital signs should be a key thing, and really a full set of vital signs is pertinent. So temperature, if you can check a temperature, I know that probably isn't a norm that you do all the time, but a temperature would be something, respiratory rate greater than 20, a heart rate greater than 90. You're not going to check a white blood cell count. That'll be something that they do in the hospital, but those first 3 should be big red flags for you. If they meet 2 of those, okay, and there's some sort of symptoms, so we talked about the cough, the red skin, the chills, the rigors, dysuria, flank pain or diarrhea, and then they have 2 abnormal vital signs, that is considered, so you have SIRS, this is considered sepsis. That is a sepsis diagnosis. Okay? Severe sepsis, which you probably will see in patients too. Again, you'll not know all these, but altered mental status. So you go out and a family member says, hey, they're altered. I feel like a classic patient that we see a lot of is like a 70, 80-year-old individual goes out, they're kind of altered. Maybe a little bit of a temperature, maybe not. They might be low temperature, like 35.8 or something. And when that happens, hopefully that will trigger, hey, maybe this is a systemic infection. We should catch this sooner. Because really, they can move to each stage quickly, like minutes to hours is what we're talking. So this is really crucial, just like when you think of trauma, brain attack, get them to the hospital as quick as you can. A blood pressure, so if they have a low blood pressure, less than 90, immunocompromised again. Lactate again isn't something you'll draw out in the field, but something again to keep in mind. So something interesting, we actually just were in a meeting this morning about these, I guess you could say statistics. So our statistician has pulled numbers just for the university. And they found that this lactic acid, which we draw on a blood gas once you bring a patient to us, and they found that patients that have a lactate of 2 or greater and do not get fluid quickly have a 32% mortality rate. That's really high. That's super high. For patients who have the same symptoms and whatnot and get fluid treatment quicker, we've found that they have a 13% mortality rate. That's a huge change just from one intervention. And we'll talk about that in a little bit of what we want you to do and help us with, but that's something to keep in mind of how quickly interventions can change somebody's outcome with this. If there's questions or comments, please feel free to share as well. And then you have septic shock, which is not a good situation. We're going to look at a lactic way high. Again, you wouldn't know that, sick. You've seen sick from patients, but something to keep in mind of, we would draw that. But really your thing would be your blood pressure. If it's continuing to drop and not get better, they're probably to the state of shock. So again, I kind of broke these down in just to one slide so you kind of get an idea. So inflammatory response, this is really, the SIRS is when it's the systemic inflammatory response, is your immune system's ramping up to fight some sort of infection. And again, if people already have wounds or they have other infection going on, they're going to have some of this. But you want to have 2 of these criteria. So temperature, heart rate, and respiration rate are the things we want you to remember. This is kind of picture format, but if they're shivering, they're complaining of severe pain. A lot of people, when they have sepsis or a systemic infection, complain of like flank pain. And I guess we kind of sometimes forget something simple like that. But if they're saying, hey, I have really bad low back pain, they have a high temperature, they're breathing faster, their heart rate's up, that is criteria for this as well. They're pale skin colored, which could mean a lot of things, but something to keep in mind. They're really difficult to arouse. I feel like I might die. So you have patients that, with stroke, say I've had the worst headache of my life. With sepsis, you might feel something like, I just don't feel right. I feel like I'm going to die. It's something a lot of really sick septic patients have said, or looking back retrospective, felt like was going to happen. And then shortness of breath as well. So here's that the SIRS leading into sepsis. So you take your criteria here, you're going to add them to symptoms. And I'll show you here in a slide. This is kind of hard maybe to remember all the signs and symptoms, but there are a couple 4 questions we want you to ask that will really be beneficial, that will probably narrow this in quicker to help you know if you need to transport and implement some interventions. Again, this is another slide with the game changers leading into severe sepsis. Once patients move from sepsis to severe sepsis, this is when mortality rate really increases. So if we can catch people when they're in the SIRS or the sepsis stage, they're going to have far better outcomes than if we're waiting. And people wait. I'd be guilty of that. Healthcare providers, I don't want to go in. I'm going to just stay home and deal with it. A lot of times this can happen as we get sick really quick. So you might be going out on patients that are really in severe stage, which if you can get them to us quick, get them some fluid going, they're going to have better outcomes. And then the last one is shock. So here are the questions we want you to ask if you're able to. Sometimes you're going to have a patient that's not conscious. So I understand there's obviously some barriers to that. However, have you had any recent surgeries or procedures? That should be a huge red flag. If they have abnormal vital signs like we talked about, and then they're moving into this state of having had surgery in the past couple weeks, or they have a wound that's not healing, like a chronic wound, we get elderly with kind of some pressure wounds, that would be a first one. Any recent illnesses, if you had the flu, if you had pneumonia, anything like that that you might want to ask would be huge. A urinary tract infection, even having been on antibiotics, might not have cleared it. It could move into a systemic infection. Kind of mentioned the wound and open sores. And this last one's kind of interesting. Why do you think we bring up the spleen? Any ideas or wild guesses? Yeah. So this has come up because we had a scenario like this in the ER. So there was a patient that actually came in through triage, checked in through the front, kind of was sick but still stable, so we were busy. So they kind of got put back in the waiting room. Didn't really get, yes, very young, so 32 or 33 I think. Super young, so we think healthier. Put him back in the waiting room, and this outcome didn't turn out well for this individual. And unfortunately, we missed this. So when people do not have a spleen, that is an organ that helps cleanse the blood. And really, it's a really infection fighter. And so when patients do not have a spleen, their body can't break down and fight that infection very well. And so it ends up
even if
bad.
they have a partial, so they just have any operation to it, it's not going to be classified. Because he had a partial splenectomy, so they thought it was working, so they kind of ruled that out. But it was actually classified, so any symptoms.
Yeah.
And guess what it's infection from? Say it like you
Do you want me to repeat? Mike? Oh, my good? Okay.
drug use, like
Yeah.
dog saliva.
Yeah. His own pet.
His own animal.
Yeah.
These are normally
Yeah.
That's a really crazy case.
No, which, again, we say that for an extreme, but it happens. And so simple questions like this, and honestly, I've talked to a few of nursing staff since then. We've caught a couple cases that they had partial spleen or their full spleen removed and they had better outcomes. But a bad experience led us to realize we need to be more proactive. So definitely something to keep in mind. That when I learned that, I was like, oh, I didn't think about that. But really key when you understand the behind why, really beneficial to ask. So this is what we currently have in the ER. So Emily, our educator, and some other providers and team members came up with this. And this is what we do on our end. So once you bring us a patient that we think is concerned for sepsis, this is what we do, okay? We're going to hopefully not call a code sepsis, but it happens. And again, this is criteria. We're drawing blood to reinforce and support why we're doing this. But you can see it's a very long checklist, but this has been really beneficial. In our meeting this morning, we've actually have 90% better outcomes, and we're catching patients about 90% of the time, which our goal is 100. We don't want to miss anybody, but that's a huge improvement from like 30 or 40% a year ago. So this is really huge for us to be doing that. This kind of continues on. So our goal is to obviously get blood cultures, treatment, and get them admitted as soon as possible for further workup. So this is an example of ours. Nate, will you pass out this? So this is really why we're here. We want to work better with you. We want to improve patient outcomes, and we want to have healthier, hopefully improved patients that will be grateful for what you've done for them. So this is a checklist that I worked to put together with Dr. Scott Youngquist and Dr. Kirsty Hopkins, who's medical director over the ER. And this is what we're bringing to you to have you help us pilot and kind of work. And I put it in a checklist type format for you to kind of have brief. I can check it just kind of as a reminder and hopefully help not have to remember all the exact ranges with vital signs. So what we want is earlier recognition from you. Because if you can, I know you get calls, sometimes you're like, do we really need a transport or not? I hope after you ask a few of these questions, you'll know more clear. Hey, we really think you need to go, this is why. It gives you that education of helping them understand why they need to come in. Then we want to implement this checklist with you, and we're going to trial it over the next few months, especially right now through, so I don't know if you remember this, I'll go back a little bit, but the numbers, if you look at the months that were most high, I mean, I can't discredit these ones. I feel like season changes. But you can see October, look at from September to October, the jump. How many more patients? Not only were we seeing 21, we went to 87, then 91, 104, 92. I mean, a lot of them were over the winter months because you have flu. We're about at that. We're going to start measuring hopefully by the middle of November, and we're going to measure it through the year. But over the next 3 months, we really want to see, one, are you bringing more patients to us because you're catching it sooner? And two, with interventions, how it's impacting patients down the road. So kind of something to keep in mind with that. So we'll kind of move back to this. So here's a bigger, I kind of cut it in a couple, but what we want you to do is here's your criteria, okay? So it's a reminder. It's a quick reference. You're not having to try to recall it from memory. But this is what we're going to ask from you if you can get full set of vital signs. Okay, so a temperature, heart rate, respiration, this is going to be key for us and for you to really be beneficial. And then we can use your set of vital signs to continue to track once they arrive with us. So if you can, I put spot for you to write it where you can remember. And then here's really what I want to focus on today. So looking at research, and I'm not going to go into all the articles, but there are tons of research teams doing different studies to figure out outcomes for patients. And for us, particularly with Dr. Youngquist, they're finding fluids are even more effective than antibiotics right now, which is crazy to think. You take both and do them together, patients are going to have way better outcomes. But what we want from you is IV access, Okay, 20 gauge is completely fine. It doesn't need to be bigger than that. 18 if you want, but really just get IV access if you can. Second thing is fluid. So I was told you guys carry NS, is that right? Somebody was saying LR. Dr. Youngquist wanted to try LR, but I heard you don't. So we're gonna focus on NS. I want you, so this is the kind of formula, 30 mLs per kilogram. However, think of 1 liter. Just that's probably an easy way to put it. If they're capable of taking a full liter of fluid, you can start it. And we want as quick as you can get it in. Sometimes we'll put them on pressure, wide open, pressure bag, whatever you want to do. Get that liter of fluid in them as quickly as possible. If they have like congestive heart failure, renal disease, so I know you ask usually past medical history, if they have a restriction of fluid, studies are showing even being that sick, they need some fluid. So we want you to start a 500 ml. If it's a 1 liter, you can go slow, but go slow and see how they tolerate it. If it's a longer transport, which hopefully it won't for you because it's pretty close, but starting this and then starting more if they need it. But their patients have far better outcomes. If the tank's not full, how'd you put it, Nate? Tank's not full, it's not going to do any good for us to do other interventions. He's like, I put him on the spot. So really, patients need the fluid. It really helps with infection fighting. So those are the main things we need from you and want. If you can and you have time or a patient can talk to you, asking them, hopefully you've asked them these before you've started the interventions, but just kind of a reminder, have they had recent surgery? Are they sick? Do they have a wound? Things like that to kind of mark. Then we're going to have you, I know most of you usually call. You don't have to make this a long report, but when you call, say, hey, we have a patient we're concerned for sepsis with. Well, that's going to not only trigger a charge nurse, she can pass that on to staff. We're going to be more prepared to implement and get things rolling quicker. And then once you get them transported to us as soon as you can, we'll get report from you. And I'll kind of walk you through this next step with. So in our electronic medical records, there's not, unfortunately, a way to break up your crews versus other EMS crews. So when you all bring patients to us in the ER, there's that HUC station right there. You always ask which room you go to. If that kind of rings a bell. We want you to check in there with them and just say, hey, we're concerned for sepsis. Is that, so when you come in the doors, there's somebody usually sitting there. That's where we want you to stop. And just say, hey, we have a patient we're concerned for sepsis. They'll take it from there. But they're going to actually track that patient, and we're going to pull data on it so we can give that back to you. And some of the data we're going to actually, I'll pass this around so you can just see what we're going to ask for. But the biggest thing is we'll go back and look at charts, and we're going to compare how long patients are staying in the hospital, their outcome, so mortality versus, positive, negative outcome. And then we also will ask questions, kind of delve further into that, but then also look at cost. How much is it costing not only facility but a patient with this? So our goal is to hopefully improve. So this is just those steps when you call report. Are you kind of the only main paramedic transport? Okay, fair enough. Well, you're all getting trained, so okay. Fair enough. Okay, we're almost done. So, but that's just kind of the process, and then this is obviously something we'll publish and hopefully look to see nationwide how that's going. When you give report to the nurse, if you can, the biggest things we're going to ask are these two. Did you get an IV going, and how much fluid? Because we're going to start documenting. Yeah.
With Salt Lake's response and how it's set up, I see a little bit of a problem implementing the pre-hospital fluids if they're not hypertensive. If the patient's hypertensive, these guys will get a medic crew come in to do it. But if they have a mild fever and they have a pulse of 110, I have a really hard time seeing the BLS crew saying, hey, let's get medics here to start an IV for this transport. And so that, I think, is something, that's going to be an issue that you guys are going to run into with implementing this and
that's good to know.
Pre-hospital fluids.
Okay.
Even if I think we can talk to Dr. Youngquist, even if they identify it and still
Yes.
bring them, and then we can talk to fluids?
Yeah. I think that's the
We can do
biggest
that
key.
as a basic EMS crew.
Yeah.
As a
Yeah, they would.
Yes.
We're happy to identify, but if we're gonna need to, one, find this information, call for paramedic,
Yeah.
we're
Prolonging.
prolonging the transport. Now, it's 3 or 4 minutes till we get a medic there, and it's you're gonna save 3 or 4 minutes
Absolutely, yeah.
by calling a medic and getting, that's really, and now you're tying up 2 crews on a lot more calls.
Okay, no, fair enough. And that's
If we
great
can get them
feedback.
transported, if we can start to identify some of this and get them transported quickly,
Yes.
we're better off than tying up a paramedic unit.
Good,
We
okay.
can't start IVs, we can't do that as
Yeah.
a basic.
No, thank you for bringing that up.
Is
That's
this
good to
something
know.
you're gonna be
Document.
talking to young
EMT
push about and things of
Yes.
this?
Yeah.
So,
IVs.
one thing that I think would make it so a lot more patients are getting fluid, cause it's kind of with that same situation. A lot of medics, if they are stable,
Okay.
and they have a mild fever, a little tachycardic, but everything else is fine and their blood pressure's great, a lot of times, they're probably just gonna call and send them.
Okay.
So that way they're not going out of service just to do
Out of that.
a,
Yeah.
a
Okay.
small IV. If there's a way that we can set it up to just do a quick IV on scene and let a bolus go, obviously if there's CHF or something like that where it's a little more concerning,
Yeah.
then we'll go with.
Okay.
But to get pre-hospital fluids on the patients who are just in like the SIRS category
Mm-hmm.
would be, you get a lot more if we were able to do that.
Just send a BLS.
Okay.
Just send a BLS
Send a
with an
BLS.
IV and
Okay.
have Gold Cross monitor the bolus.
Thank you for
Bring this up. See, you're here to help us too. It's a work in progress. That's great feedback. So, and that's the thing, like, honestly, if you're picking somebody up and you know you can get them to us in like 6 minutes, really the key would just be, hey, identifying, hey, I asked them about this, they have a wound, their heart rate's this, their respiration or temp's this. That's just huge on our end, because sometimes it is so busy. ER, I know you guys are busy too. We don't want to delay you. But on our end, just to be able to communicate that, I think will be huge. So, no, thank you for bringing that up. Great points.
To start recognizing that, and cut our scene time in half.
Yeah.
Get 'em going
Absolutely.
now.
Okay. Yeah.
If we're recognizing some of these, at that point, it's time to go now.
Okay.
And get them moving towards where they can get that care, rather than trying to
Delay it or wait.
delay or wait and figure things out. Just
Okay.
to get them going, we're gonna save more by getting them to you now than 10 minutes from now.
Yeah, absolutely, and that would be fantastic. And this is going to be together. You guys are going to provide feedback and insights that we didn't even think of. So thank you for bringing that up. That's very beneficial. And if more come up, please pass that along. This isn't a set in stone. This is where we're trialing it out. We're just trying to improve patient
Care from the beginning to the end. So this is just, again, those steps. I have these printed. I don't know if it's helpful to keep on ambulances or where you want. I mean, we can send this in a file format so you have access to it. But again, you don't have to memorize all this. Even in healthcare, there's so much to know. We don't memorize it. It's just knowing your resources, knowing your tools. And we wanted to give you a tool that hopefully will help kind of trigger and get patient care, improved all together. Yeah. Yeah.
Dr. Youngquist work with Herman, and I'm sure the guys who do the paperwork don't hear this, but we use the iPad, right? And
Yeah.
in our patient care reports, there's also a tab on the side, if it's cardiovascular, whatever it may be, you can have that sepsis, you click the box, it opens it up, you start going through and checking these boxes.
Okay.
Checklist.
Yeah.
That would be fantastic. That's awesome. Okay.
So, and he's working with that. And then, question was brought up, this is just a you, if we call another hospital, we take,
Yeah.
30% of our patients to you, the rest go to everywhere else.
Correct.
It's not gonna matter to them.
No, they're not tracking it right now. Eventually, hopefully everybody's going to get on board with this. Would it hurt for you to say, hey, I'm concerned for a septic patient? I don't know how they're going to respond to you. I would hope professionally and really grateful, but
I know LB has been doing not nearly as, brought out to us, but just from transporting patients there, they have a similar criteria.
okay,
They just,
okay.
as we give the report, they'll check it.
Cool. Okay.
Check it and implement
Pass it on.
really similar.
Okay. Well, and hopefully, like, no matter where you take them, just say, hey, we've had training on this. I'm concerned for this. Whether or not you do the full workup's up to you, but here's what I've found, and then just pass that on. I would assume every hospital ER would be grateful for that. So, yeah, good points. Thank you for bringing that up. These are just resources or references. I mean, if you guys want access to this to read, you're welcome to. I can send it out. So like I said, we're trying to do like a quality improvement project. So I'm going to have Megan pass this up. It's very similar to the survey you did at the very beginning. But be honest. We want to know if this is beneficial, what we can improve, how we can change things if you don't mind. And then I have, it's not tons of candy. I go out a little bit healthier. But I have crackers or like little panda cookie things they'll pass around. So you can take some of both if you want to pass those. So any questions as well? Thank you for your comments and input. That was fantastic. Super helpful.